Good afternoon, everybody. Nice to see you all. It's probably too late to say Happy New Year now, but you know, it'll soon be 2021. Welcome to, I presume a lot of these people we got behind you there are probably from Ashby, so welcome very much this afternoon. So this is a meeting of, the first meeting of this year of this calendar year anyway, of Health Overview and Scrutiny Committee here at Leicestershire County Council. Just like to remind everybody that it is broadcast live. There's a picture up there behind of me, sadly, at the moment. But it is live, and then afterwards it gets archived, and it's always available then. It's actually, we've changed the supplier now, so it actually is a YouTube video. Just makes it, you know, lots of people have YouTube on these things, don't they? Which reminds me to turn it off. Right. Yes. So the other thing is, as I've done to talk to you now, if you can remember to, when you're speaking, to turn on your microphone, and then particularly afterwards turn it off, because there's only a certain number that can be on at the same time. And then the other final announcement is that Mr. Crooks there, Mr. Bill Crooks, is substituting for Dr. Sarah Hill today. It's the only one there. So we start on the meeting. Minutes of the meeting held on the 13th of November 2019. I propose the minutes are taken as read, confirmed and signed. Can I have an agreement generally? Thank you very much. Question time. I've not received any questions from any members of the public. This is the opportunity, by the way, for those of you behind. If you had any questions, that was the time you should have written them into our democratic services a week ago, and then they would have been brought up at this point. But there weren't any. Questions asked by members under Standing Orders 7.3 and 7.5. I've not received any. Any items which are urgent, I've not had any particular request to have any items moved up the agenda, so there are none. Declarations of interest. Anybody declaring any declarations of interest on today's? Thank you very much. And then declarations of party whip in accordance with the overview and scrutiny procedure rules. Do any members have any declarations to declare? Thank you very much. Presentations of petitions under Standing Order 36. I've not received any petitions either. Okay, so we now move on to item 8 in our agenda pack, which is Community Services in Ashby, pages 13 to 60. For this item, we've got West Leicester CCG Caroline Trevithick here, and Tamsin Hooton, Director of Service Improvement. And we've also got Rachel Bilsborough from Leicestershire Partnership Trust. We've also got the representatives of Ashby Civic Society, basically, so it's Dr. Neil. And thank you very much. So both the CCG and Ashby Civic Society are going to be allowed a maximum of 5 minutes to speak, and Ewan here is going to time you. Before we actually start that bit, though, just perhaps a little explanation to, particularly I think, to the members of the audience here. We are a Health and Scrutiny Committee. We have no statutory powers to make decisions on things. We can advise, we can ask questions, and we can, like today, bring matters which are obviously seen in public because they're on the webcast, but we actually have no statutory powers. There are other bodies within the health and Community County Council side which do have statutory powers, but we don't. We are purely, effectively, overview and scrutiny, as it's called, just to make that straight. I think it's important because a lot of people think your committee, you must have some powers. We don't. We have lots of powers in terms of questioning and raising issues and so on, but we don't actually have a specific question to actually make a responsibility and so on. But anyway, let's see how we go. So I'm first going to ask Barbara Meal to explain why this issue has been raised with the committee. Barbara, you've got your 5 minutes.
So I'd like to thank the committee for allowing us to attend and present at this meeting. Over 4 years ago, I attended, along with many representatives of the Ashby community, to present our concerns and predicted outcomes for the closure of Ashby and District Hospital. It's with much sadness that I return today to report back the results of this closure, which have been closely followed and recorded in Mr. Bedford's report, a copy of which you've been provided with, together with my summary document. In September 2015, Ashby Civic Society asked unsuccessfully for your help and support in scrutinising the plans and actions of the CCG and Leicestershire Partnership Trust. We asked you to challenge the CCG and LPT, to ask why services were to be dismantled before effective planning and preparation has been completed and before clinical and financial benefits have been proven, to ensure that effective performance and outcome indicators were in place, to consider the financial implications of failure, and, for the sake of patients who either live or die as a result of this service inadequacy, demand to see what contingency plans are in place in the event of a breakdown of services. In our view, these concerns have become reality. Our report sets out the details of the Fit for Future Ashby Community Health Services Review. It describes the 2013 public consultation process and commitments made by the West Leicestershire CCG in the event of the chosen option to close the Ashby Hospital. The report sets out our attempts to secure the promised commitments and where they have failed to be delivered. The CCG report today acknowledges that the decision to close the hospital supported the recommendation to increase the range of community services in Ashby ahead of any changes provided directly from the hospital. In fact, the CCG's own report states that the 2019 public feedback was predominantly negative, C point 9, and I would draw your attention to the penultimate point where somebody had raised scepticism that the CCG can tackle long-standing issues and make a positive change. A new model of community health services have only just been implemented in December 2019. It seems to offer all the things we were promised 5 years ago, and in fact is still in the planning stage. Therefore, one can only conclude that nothing has changed for the better. We do not have an improvement, but a deterioration in services offered to Ashby. We were promised an improvement, a state-of-the-art one-stop shop. This has not happened, and indeed, as evidenced by point 19 to 20, has led to a scattering of services which is not directly comparable, and many are outside of Ashby. Only 25% of Ashby patients requiring care in the community hospital have been accommodated in the promised Colville or Loughborough hospitals. On the matter of discharge to community hospitals and care homes significant distances away, it is clear that recent attempts to improve discharge from Burton and Derby acute hospitals has only come around as a result of our inquiries. Similarly, the provision of short-term reablement beds in 2 care home in Colville has only come about since our inquiries. Why could a care home in Ashby not be provided? Ashby has lost its community hospital and one of its GP practices. This is against a background of a considerable increase in population. We now look to the CCG and this committee to bring about the promised improvement in community health services and to effectively monitor and report on a regular basis to the public. In their response, the CCG mentions the use of Section 106 monies, an issue in all the national newspapers at the moment. These funds were available in 2014 and could have been used for the benefit of services. Why did the CCG not wish to make use of them? In 2015, this committee was advised that legal grounds for referral to the Secretary of State were if the consultation had been inadequate or if the proposal was not in the interest of the health service of the area. The committee felt this was inappropriate. But I would also like to note that in 2015, Councillor Kaufman requested that there should be regular input of what is going on. This was agreed by the Chair. This is not minuted in your documents, but is on the video recording of the meeting. Can you confirm whether or not this has taken place, and if not, why not? So again, we ask this committee to scrutinise this issue of the closure and of the Ashby District Hospital and the provision of community health services. Thank you for your attention.
Thank you very much. Thank you. Before opening it up for questions, I feel it's important that obviously the CCG get an opportunity to respond as well. So I don't know which of you wants to have a go, but perhaps Caroline. Thank you.
Okay, thank you, Chair. If I may start, conscious of time, I want to take the report as read. But the report does put up a lot of historical information in for members who weren't around back in 2013-14 and subsequently since we've been making the changes across LLR and West Leicestershire and North West Leicestershire particularly. I'm going to ask Tamsin Hooton to focus predominantly on the community-based services, but before I do, I just want to kind of pick up some of the issues around outpatient services. One of the things that we know about outpatient services is that our model of outpatients needed to change and does still need to change. And we've been working really hard with Castle Medical Group to provide outpatient services locally in Ashby that aren't necessarily the same as what was provided back in 2013, but provide more of a service for patients who need repeated outpatient services, so diabetic follow-up or therapy follow-up or specialist nurse follow-up rather than a consultant follow-up. And that allows us to bring the consultant follow-up that's maybe one visit at a time to go to the Colville Community Hospital where we've got the broader range of diagnostics. But we've also put those diagnostic services into Castle Medical Group as well to ensure that we've got a different model of outpatient services for there. And we've got additional business case happening to use Section 106 monies to further expand the property and therefore expand the services that are going into there. So it's an evolving process around that. But I think particularly, I'm going to hand over to Tamsin now to talk about the community offer.
So, as the report notes, we've been doing some really significant work to look at community services, not just in Ashby and Colville, but for all residents in Leicester, Leicestershire and Rutland. And I think it is fair to acknowledge there has been some negative patient experience in community services. That's something we're really concerned about and aim to put right. So we've done really significant engagement with local populations, including at Colville, prior to now trying to strengthen those community services with significant investment from the CCG. So in the first wave of investment, we've got £2.5 million going into additional community services across LLR. And that is primarily to strengthen people's experience of home-based care, and we'll be moving on to consider the services that are in community hospitals as a second phase of work, and that phase has now begun. I think what we would acknowledge is that community hospitals are a great local asset, but there are lots of reasons why people would be admitted to a community hospital, and proximity to home is not the only and determining factor. So it's really important when people can leave an acute bed that they do for their own recuperation and reablement, as well as the need to use our acute beds well. We always offer people a choice. People sometimes choose to be closer to their families and not to where their actual postcode of residence is. And patients sometimes need a specialist type of bed which isn't provided in all of our hospitals. So they may need a bariatric bed or particular equipment or particular observation facilities. So we make sure that patients get the right bed for them and offer them a choice of where they want to go, and that's really important to say. We have been working really hard with Burton and Derby to make sure that they use our discharge pathways rather than their own, and we've really improved their ability to get patients back to Leicestershire services over the last 6 months, and that's been a success. So I think we're on a journey around community services. I think we should really be pleased at some of the changes we've been able to put in place over the last 6 weeks, including the provision of 7-day reablement therapies and much closer working between health and social care. But we need to acknowledge that we won't rest there, and we continue to work on that improvement. So I think I'll stop there because I'm pretty sure that there'll be lots and lots of questions, and I want to leave as much time as possible for that, if that's okay.
How much time is it? I'll mention it now before people chip in. As well as the papers you've got in front of you, we've also had sent to us this week, I've had reminded basically of some of the papers we've had over the last few months, but one of which was I had a specific letter from the Ashby Town Council, and basically re-emphasising their support for the questions that the Civic Society have been asking us. And also this week we've had some concerns raised by 2 members of the Labour group at County Council, Terry Einan and Sean Sheehan, and a copy has been sent to the CCG, so we might get some of the answers to their particular questions, mainly around, not just, but around transport problems and so on. And we've also had a note from the member who represents most of the area around Ashby, John Coxon, also asking, particularly, he's pressing similar questions really, but he also wants to know what's being advised, for example, of the future use of the building, and what its future use is anyway. He talks about the public workshop held about this time last year, and the same thing really, what's been asked, that what's happening to the services that have been promised for the local settings. So I think we've had a fair good input from the local town, the local councillors. So let's just open it up for some questions. Anybody got a particular question they want to start with, or are we? Tom. Yeah.
There seems to be some sort of acknowledgement that there is quite a considerable room for improvement in the services, and you're taking measures to adopt that. What are the chances of the Ashby Hospital being reopened?
So the Partnership Trust owned the site. The site was sold subsequent to the hospital closing to a developer, and I understand has subsequently been developed. So there isn't an option to reopen the hospital as it was.
Thank you. So the only option really is to improve the local services, and the other, which is you're putting money in to do that. And the other thing that seems to be of a great concern is the distance people have to travel to get to the equivalent of a community centre when they're discharged. Those are the hospitals that are available in Colville and Loughborough. There are no closer hospitals. Ashby Hospital won't be reopened. So is there any solution to that problem apart from home care? Because I think that's what the Ashby Civic Society want to know, and the Town Council. They've been promised things 5 years ago. They haven't occurred. Now there is a lot more money going in, and to my mind, we probably need to have a look at it again later on, see how things have improved.
So thinking about beds specifically, those beds will normally be, people will be admitted to those beds after discharge from hospital. They'll be transported there from the acute hospital, so we're not asking people to find their own way to those hospitals. So I think the issue of transport really is for carers and loved ones that want to visit. And as I say, there is a conversation with that individual and their family about their choice of which hospital to go in. So if a patient strongly doesn't want to go into a hospital that isn't Colville, they would not be forced to do that. Where possible, we will try and get that patient home, but some patients are still medically recuperating or need 24-hour care, and therefore do need an inpatient bed. Over the last 2 years, we've significantly increased the number of what we call discharge to assess or reablement beds, and we commission those through a number of care homes. Those beds were historically commissioned on a spot purchase basis and didn't have therapy input, and we've redesigned that pathway, so now we only purchase from a limited number of care homes on a procurement framework or on a block contract. There are 2 homes on that framework within Colville. It is our intention to expand that service, and so we are dependent on providers coming forward that can offer the right quality of care for patients, but there is absolutely no reason why we couldn't work with a home closer to Ashby than Colville if one comes forward, and it is our intention to significantly increase the number of homes we work with. So that's a definite positive possibility there. The other thing I think I would just really stress is, it's absolutely our intention to make sure that people only go into community hospital if they really, really need that. So when we did a review of community hospitals, we found up to 50% of patients in those beds could have been in somewhere that was better for their needs, either at home or in a care home environment that is more like a home environment where people are encouraged to move about and be more independent. So, and we're continuing to pursue that strategy with some success. So, but we're not where we want to be yet.
Thank you. That clarifies a lot. I mean, the actual number of people on page 23 of the report that are discharged between October 14 and 2018 into community hospitals seems remarkably small. It's overall it's 233, with Melton Hospital ostensibly only having 4 people admitted. That seems odd.
That's just patients with an LE65 postcode, as I understand it. So we have, I'm trying to remember how many thousand, we have about 2,000 admissions to community hospitals
Yes, roughly,
a year.
yes.
So, but what I did do in advance of this meeting was to have a look at how patients map to their nearest community hospitals, not just for the Ashby population, but for all of our patients across Leicester, Leicestershire and Rutland. And really interestingly, across both 1819 and 1920, the average for Leicester, Leicestershire and Rutland was 46% going to their nearest hospital, which is bang on the figure for Ashby. So I want to assure you that Ashby patients aren't being treated differently to patients across the rest of our patch, but there are often very good reasons why patients are going not to their nearest hospital. So they're often clinical and sometimes through choice.
Could I just add to that reply in that from a clinical perspective, the clinicians within LPT feel really strongly that the sooner we can support a transfer from an acute setting of care either into a bed-based option or a home-based alternative, the better the outcome, clinically, the better the outcome for a patient. So we know that the longer a person spends in an acute setting, the worse their outcome will be. So our primary concern is better outcomes for people in supporting them to step down promptly. That isn't always as close to a person's home that we would want it to be, but we know that will lead to a better outcome for an individual.
Well, thank you, Joe. It's more of a question of hoping to maybe talk outside of the meeting. I'm from Health Watch for Leicester and for Leicestershire, and I attend a number of meetings specifically around things like the community services redesign and what's emerging with the community hospitals redesign. And I would feel I'm not doing my job properly if I don't understand your concerns thoroughly and kind of understand them from that perspective. So I'm just would love the chance if we can connect kind of outside of the meeting so we can have a proper discussion.
I've just been listening to the CCG, and there were two words that stuck out in my mind. Well, it's three words actually. Historical and evolving process. Can I just remind everybody in this committee that we were here over 4 years ago where we were promised services would be in place, and we have just heard from the CCG that they are still developing plans, they are still trying to improve. So why should we have confidence in their ability to manage the community health services in this area? And I would ask this committee, where's the information that you've been receiving or supposed to have been receiving over the last 4 years as to how this process has been progressing? Because it's all very well saying we've got plans, we would like this to happen. By this stage, before the hospital was closed, they should have been in place.
I was going to say that, yeah. Yes, I've been chairman, I think, about 2 years, but I know it was obviously going on well before I became chairman. But we've certainly had presentations here in that last 2 years. This is not the first one. So there have been opportunities for members of the Ashby Civic Society and also the CCG to make comments about it. So we have had presentations. Yes, we have.
Yeah,
You've given them.
Sorry, but we haven't been informed of the result of these discussions.
We haven't been invited.
No. Sorry, you've come to the meetings though. You've attended the meeting. This is our meetings. We don't have any outside this meeting.
But it does concern us.
Yeah,
We can't come to every meeting. We depend on
That's right.
you to look after our interests.
Yeah.
But taking that aside, we're still 5 years down the track.
Yeah.
And the services that were promised to be in place before the hospital was sold are not in place. And we have no firm promises of them being in place. So yes, that may be the case, but I think there are more urgent issues that need to be considered.
Yeah. I know you're part of the Civic Society, so I'll...
Can I just, thank you. Can I just focus again on the community beds and what the CCG is now saying about those? I'm not saying that this is the most important part of what was going to be delivered for us to make a service that was fit for the future, but I am concerned about this particular one because in the planning of phase 2 of the community service redesign work, which I understand is about to happen, the CCG says it will begin to develop options for a community bed model with the expectation that these will support the production of a pre-consultation business case, and we will be engaging with local people as we develop the next set of proposals. I have to say, oh dear, déjà vu. This is exactly what happened prior to the closure of beds in Ashby. We are concerned now about our beds, our most local beds in Colville and Loughborough, which we feel will no doubt be on the table. We're concerned that a consultation may be held again and that the public at large may not get to know about this and get to understand what is happening. And I feel that the only place that we can turn to, because we think the only body which is able to question the CCG thoroughly, is to you, the Health Overview and Scrutiny Committee, and to ask you how you're going to ensure that the CCG's work is good and proper for the future for us. Are you going to be calling them back, please, and to insist on some smart scrutiny in the terms of that business terminology, specific, measurable, achievable, realistic and timed, so that we know what they're going to deliver and how and when, and we can see the results of it, please.
Fair enough. Understand what you're saying. As I said, we have overview and scrutiny. There are other health boards, of course, which are part of this system, which, as far as I'm aware, you've not talked to at all.
Oh, we have. Oh, we have.
Everybody, from the top down.
I understand.
Yes.
I've asked today. No presentation has been made to the Health and Wellbeing Board, for example.
That's probably since before we started. We were frequent attenders at the CCG, at the board there,
I mean,
making presentations,
it may not
etc.
know, but all I'm saying is they have far more responsibility than we do. They actually are a board, proper statutory board. Anyway, any other points from the members? Yes. Yeah. Well, Maggie.
We'll go take Amanda and then
Go
I'll...
on, Amanda.
Okay, here we go. We have lift off. Actually, I just had a couple of points, if I may, please. Tamsin, in the previous response, you talked about 46% are going to their most local hospital, and that data is what was presented from the Civic Society paper on page 23. What is the move going forward to try and increase that number to make sure that people are going to the hospital most close to them? And I'm assuming that'll be something that's done across the trust area as well as in Ashby. So I'd be interested to hear about that. I think one of the things that, having read through the papers, obviously this isn't my part of the area, but actually, you know, health services being delivered to people locally is a really important thing that people feel very passionately about. I think the difficulty with some of this is that the time it's taken to get to this point has just been far too long. And I suppose the elements that I would be really interested to hear about is how do we not only improve and give reassurance to individuals that this service has got to get better locally. We've already heard that the hospital site is gone and there's nothing we can do to rewind that, but how do we give people reassurance that services will improve? And I suppose the sort of the very last point is I suppose that the GP services also feel like they've been changed in that time as well, with a reduction of facilities on the main high street. So I think it's not just the closure of the hospital part, it's actually the services in health in general, and I'd be really interested to sort of get a flavour of that as well, if I may.
Okay, so if I may, I'll start off. I'll start with the GP practices first because my second bit will lead into Tamsin. We've had 2 GP practices closed in Ashby over the last 6 years. The first of which was happening about the same time as we were doing the community services review, which was the need for a bigger premises, which is what they've moved to the outskirts of town and they've got a bigger, more modern premise. And that has actually enabled us to work really closely with the GP practice to put different services in. So they've got visiting consultants doing a hernia clinic, for example. They've got specialist nurse practitioners doing gynae clinics, etc. And so we've been building up community-based services there, and we will continue to do that. The second practice that was closed in Ashby, we worked really hard with the practice and the surrounding practices to see if we could try and keep that going. But unfortunately, it's indicative of practices across the country, not just across West Leicestershire or even Leicestershire, of practices, particularly where you've got small single-handed practices, that's really difficult to sustain. And we got it to the point of a caretaking practice so we could keep that based locally in the town, but that failed as well because we needed to consolidate services. So the Castle Medical Group has taken patients in from that practice and are trying to consolidate what's provided locally, and we continue to support them to do that, of which is some of the business case that we're trying to support them with to expand their premises. And we're constantly, we've got that eye over all practices across the patch. In terms of how long it's taken to evolve into the services that Tamsin was describing, if I take us back to 2013, what we were looking at the time was improving nurse-led services. There are intensive community support services at the time. And so we could improve that model of care. That's actually evolved into the work that Tamsin's described, that is much more integrated with health and social care. And again, if I take us back to the consultation, we were hearing concerns about patients falling between the organisational boundaries of health and social care. So our provision now around a home first integrated neighbourhood team brings health and social care together in a much different way. So Tamsin, I'll let you kind of finish off.
Yeah, I think it is really important that we don't make this all about the beds, because although they are important, the minority of patients are admitted to a community hospital inpatient bed compared to the significant numbers of patients who receive daily support from LPT, Leicestershire Partnership Trust, in their own homes and social care in their own homes. So we have, I think, started to have real successes in working jointly with local authorities, and the Home First teams now have daily conversations and joint package of care discussions with crisis response and reopenment in the county council. So that's been a real improvement, and that has benefits to individuals in terms of the quality of experience they're getting, which responds to some of the engagement responses we had. So I think that's really important to acknowledge. In terms of your question about how we might improve the number of patients that are admitted to their nearest community hospital, I think what I would take you back to is Rachel's response, that actually we have to balance what is clinical importance to the patient versus proximity to home, and being close to home is not always the overriding concern for the individual and their family. It's about getting them out of an acute hospital environment, which can be really bewildering sometimes. Risk of infection, risk of decompensation and losing muscle strength is really important. So a lot of families are really concerned to get their loved one out of hospital. That may be into a care home bed and not into a community hospital, and we haven't shared that information with you, but we need to take that into account. What we have been successful in doing over the last 3 years is actually reducing the occupancy of community hospitals. The more we can do that, the more flexibility we have to offer patients choice at the time they're ready to be discharged at the hospital they would go to. But we will probably never get to the position where 100% of patients go to their nearest hospital, and some patients choose not to, or they're a stroke patient and they need to go into a stroke bed, or they want to be closer to their daughter or son who actually don't live in Ashby. So the figures don't really tell the patient experience in the fullest sense.
I think probably what it is, it's a case of strategy versus operational delivery and capacity. One of my questions to start was how is home care delivered in Ashby different from across the rest of your CCG? And really looking forward, because I can't look back, what is the expected timescales now for the promises to be delivered, and how is that being tracked? So if I said what is it now and then what is it in 6 months, that's probably what I would like to see, where you are now and then where you are in 6 months in delivering on those promises. And if I may just pick up on a couple of points raised by local members, it's probably come out in some form, but just to clarify it, is what issues in social care provision impact on the CCG's ability to maximise discharge to home? That's one question. And what needs to change in order for more patients to be discharged closer to home? Sorry, there's quite a jumble in there, but if you could pick that up for me, I'd be grateful.
You're asking a question about the model of care, I think, in Ashby and how that differs. So,
or how it compares.
How it compares, yeah. So the model of care back then and now is largely a consistent model of care. There are some discrepancies in terms of how we work with the local authorities in the city, Rutland and the county. But from a health perspective, the model of care was and is a pretty consistent model. In terms of the 2015 closure of Ashby Hospital, at that time I just want to assure the committee that there was a significant investment made in community services, but that was targeted towards health. And as I think Tamsin has alluded to, there was a gap, and people told us that there was a disconnect between health and social care provision. And when we talk about an evolving process, I think that is what we have been strengthening more recently, so that we can offer a much more integrated offer that supports people along a continuum, a pathway of care, and that they step down into a local authority offer at the point that they need it, rather than there being a gap between the health provision and the local authority provision. So there isn't a discrepancy in terms of what happens in Ashby as opposed to the rest of the county. It's a consistent model of care that is deployed.
Right, okay.
So in terms of tracking, so we have a number of key performance indicators for the service that we're now commissioning from LPT. We've had the first data cut against that. We are also trying to evaluate the impact of delivering integrated care. So we what we're trying to do in that is actually look at individuals in the round and the health and social care response that they're getting, which we've never been able to do before, but we now have an IT tool that can combine health and social care data in Leicestershire, and one of the first tests of that software tool is to start to look at the impact of Home First. So over the coming 6 months we will be looking at what sort of care people are getting and what outcomes they're getting as well, including doing a quite extensive survey of patients about their experience of integrated care. I'm really happy to come back at the end of that period and describe what the impact has been. I think we recognise that some of this is sort of what we call plan, do, study, act cycles. So we set out to change the operational model. Already in the first 5-6 weeks of it working, we know that there are some things about that model that we need to change further, and so we're doing that in real time and actually taking that process really seriously as a health and social care improvement cycle. So I'm very happy to come back with that data when we started to evaluate it. In terms of your question about what are the social care issues that hinder the ability to discharge close to home, there are sometimes delays in commencing a package of care, or there are capacity gaps in social care reablement. The social care team in Leicestershire has been doing a lot of work over the last 6 months towards what it calls its target operating model, which is about increasing the capacity of its internal reablement service, and that has happened in parallel with us developing the Home First model and should yield some benefits in terms of more capacity in reablement. Packages of care are an issue, let's be honest, they can be an issue. We are just about to re-procure across Leicestershire the Home Care for Leicestershire contract to address some of the issues about delays in pickup times. Where possible, healthcare will assist social care in stepping in where that package of care can't be initiated immediately, and we'll do what was called bridging. We've also committed, actually just the end of last week, some non-recurrent resources to put health money into additional reablement support workers to plug some of those gaps across the county. So I think we recognise this now as a sort of shared endeavour and much more willingness to be flexible about resources across health and social care to make sure people get the service they need. So I hope that gives you a flavour of what we're doing, and I'm very happy to come back when we've done that evaluation and share it.
If I may, yeah. I'm fine with the stats and all useful and everything, but I'd like to see some independent data as well. So to actually have some case studies or something actually using the services, probably with the help of Mike, I don't know, or something like that. But I'd like to see something independent actually coming back to say back at what the stats are actually doing.
That's absolutely what we're trying to do as well. So we haven't concluded conversations with Healthwatch, but what we are asking them to do is undertake an evidence-based survey tool to ask people about their experiences of care, and actually also have kind of the live, real conversations with people about what they've experienced. Michael, do you want to say a little bit more about that?
We're looking to try and pilot a survey that's been developed in Plymouth, I think it was, University of Plymouth, with the specific aim to try to capture the kind of patient's experience of an integrated system. So it's not something that is predicated on the condition that somebody might be living with, but it's that person holistically and how they've been cared for across health and social care services. And very much more about what their experience, what their expectation, and what that care delivery has been for them as a person, rather than a condition. So that's something that we're wanting to try to see whether or not it's applicable, not just locally, because it sounds like there might be some interest from other areas of the country, because everyone's looking for something that gives them something meaningful across a system that has quite radically changed.
Sorry.
The people of Ashby are disappointed in our CCG. When they're ill, it's not the key performance indicators that make them ill. They're not interested in that or the stats. They're interested in actually seeing things happen on the ground. So when they read something in a magazine, such as the CCG's magazine from 2014, that we would provide a better equipped outpatient clinic in a more modern local setting, able to deal with more patients, put an end to going to one place for diagnosis, another for treatment, they think, oh, okay, well, the future might be all right. No statement has ever been made explaining why the proposed outpatients clinic has not been proceeded with. Nothing. Occasionally we have little snippets of, oh, well, the doctor's surgery, you can now get that, and you can now get that. But there were many, many people involved in the outpatients clinic. It was a really busy place. It's gone.
Was a one-stop shop.
Have we got anything better as promised? I don't think so. That's one thing. And secondly, this is short, the CCG says on their most recent report, they're working closely with our district council regarding S106 funding. We have repeatedly, as a civic society, tried to find out where this money is. It's sitting in coffers in the district council, a lot of it, and they can't explain why the CCG aren't rushing ahead and grabbing it and spending it. So they're now saying work is currently underway to finalise a business case for it. Why so late? Why shouldn't this have been done 5 years ago? So
that money
that's
was available
why we're disappointed with the
2015.
CCG.
There's £500,000 available in Section 106 monies in 2014 that could have been spent on health services in the Ashby and district area.
And just as a last point of real evidence, there's an 89-year-old lady that several of us know very well. She's been in hospital twice in the last year. In the first instance, she checked herself into an old people's home, Melbourne, because she knows she needed care herself. So obviously she didn't get a good offer of help at home, so she had to pay for that. She did it herself, and she's come out after a month in hospital, and she's again booked herself in for 3 or 4 days to an old people's home. And then she's finally come out, she wants some help at home. They said, because you can feed yourself, we're not going to give you any help. So that's a real case.
Yeah, that is. I can't answer the question about that at all. What I was going to say, though, is thank you all for contributing. I think it's been very helpful. I have asked before today, or before the meeting, I did ask if we can have just a possible proposed decision that we might make today for everybody, and it's been added to as we've been talking. So it's already longer than it was a few minutes ago. But it's not too long. I'll try and read it to you and see what people's opinion is, but I think as far as I'm concerned, having read it through a couple of times now while you've been talking, I think it has the right tone anyway. So there's this proposed decision by us today that this committee notes one, the concerns raised by Ashby Civic Society regarding the impact of the closure of the community hospital. We've heard that, and we've obviously known that from the past. The response to Ashby Civic Society's concerns produced by West Leicestershire Concern, we note that what has happened. B, that the committee requests West Leicestershire CCG to have regard to the concerns now raised during its review of the impact of home-based community care on the use of community inpatient beds and short-term enablement beds. So it goes back a little bit to what Maggie asked from the Labour comments. And C, that the committee requests West Leicestershire CCG to provide an update of progress with a review referred to in B above this review in 6 months' time, and D, that this committee receives the business case for phase 2 of the community service review for consideration. Does that make sense to certainly to the people at West Leicestershire and LPT? Yeah? Now, there's a time scale in there. I appreciate the word 6 months sounds a long time, but it's important that we keep getting this back and listening to it. I would urge you, as I said, to look at all avenues, because clearly you've done what you can. The other thing, I really do commend you. I wish we had a civic society with such energy across every area of the Leicestershire, but clearly, as has been raised by a number of people, this is not just Ashby that has this problem. It may be obviously clearly very specific to you. I mean, I live 8 miles from Market Harbour, and I don't have a community hospital in my villages, never have had. We have a medical practice, 2 of them, that really struggle at the moment. Any kind of care, you go to Market Harbour, if there's no space there, you may well be ending up in Colville or Loughborough or Melton Mowbray. But it is, therefore, you raised a big point, it's clearly important. But as I said, from our point of view, we have to look at the whole county, and it is clearly there are problems everywhere, so we are looking at that as well. But yeah, sorry.
Can I just ask, when you say other avenues, what do you mean? So, for example,
from our
could we go
point of
to
view,
Public Health
we
England?
don't just talk to West Leicestershire.
Right,
That's what
okay.
I meant. We talk to East Leicestershire. We have a joint committee with the city and the Rutland, and we talk obviously to those 2 as well, or at least they're the city CCG. So this is a theme that does come up. You've raised it very specifically for Ashby, and it's important that we work with you to get that resolution to what you've been talking about. But as I said, you have been here now for 4, if not 5 years, and we need to see this sorted.
Can I ask that you let us know the outcome in 6 months' time, please?
Yeah. I mean, it'll be on our agenda as normal, and you'll be notified.
No, sorry. Can I ask that you notify us?
Oh, I see. You actually want to be notified.
Well, yes, we want to know what you decided after 6 months.
Well, it'll be a paper like today.
Yes.
If you're quite willing to come to the meeting. It'll be broadcast like today.
Can I ask you write to us and actually tell us?
Yeah. You'll be notified. But I mean, as I said, all I'm saying is, it will, when it comes to us on our agenda, it will.
So we've got to come all the way from Ashby here to listen to the outcome.
Behind you is a large television. If you have a television in your home, you can watch it just the same. You don't have to come here. That's what I'm trying to say. But you can witness it just as much as everyone else. Anyway, yes, David.
I think what you're suggesting is fine as far as it goes, but I mean, we've been here before, and it's a very sensitive issue because it affects all of us in one way or another, because we all rely on the NHS to a greater or lesser degree. And I personally, I've known Mr. Bedford and his team for a long time as well, so I know how sincere they are. In fact, we consulted Frank and his team when we were going through the Hinckley situation. So we're all following this very closely. Now, I'm just wondering, in addition to coming back in 6 months' time, could we set up some kind of dialogue, ongoing dialogue, so that as this is put together, as the report in 6 months' time is put together, there's input from the CCG and the civic society in order to ensure that we actually address some of these issues that have been raised. I mean, Ken just raised the issue about the Section 106 monies, which we haven't. There was no answer to that, and that is a vital question that needs bottoming out. So I'm just wondering whether between now and 6 months' time, the officers could work with the interested parties to try to go into these issues that have been raised today in more depth. I'm just wondering whether we could have a working party of members who could call upon the various people to go into this in more depth, because I don't want us just I don't want people to go away thinking, oh well, that's been put off for 6 months and nothing. I'd be happier if there was if we could actually have some further investigation into the points that are so obviously in people's minds.
I'm looking a little bit to the CCG and the LPT because clearly you're going to do the work, and it's, you know, until you get something down on paper, it seems rather little sense in us, therefore, you know, pestering you for more.
Yeah.
So, but anyway,
I think my concern about bringing it back together as the concerns that Ashby's raised, and I absolutely get the Civic Society have raised the concerns for a reason because they're looking at it holistically. The way we would need to cover off the issues are separate. So you'd want a primary care response. You want to know what we're doing around the general practice. You want to know we will be coming to you at some point with our outpatient services redesign. Tamsin's leading on the community services redesign. So it's how we're covering all of the aspects, but it won't be done in one response. It'll be done in a number of presentations to HOSC over the next few months. We will be there. So I suppose it's how we can alert through corporate services that bit of it is, we're going to go down into that bit of it on that occasion, and that's the only thing I can kind of think of, rather than trying to do it separately, because it skews it then towards Ashby, and I'm sorry to say this, but we've got to look at it from a LLR or a West Leicestershire perspective. So my proposal would be that we kind of alert as to when we're bringing updates back or when you've requested us to come. But we've got a process of feeding into Health and Wellbeing Board around the things in responding to the National Long-Term Plan that will pick up all of these aspects over the next year or so.
Hi, yeah. One of the issues that has arisen over the last 5 years has been the difficulties getting concrete information from the CCG. You know, Frank used to have black hair. Would it be possible for the CCG to copy us in on their reports? As a member of the medical profession who's worked in the health service for 30 years, I think I'm suitably qualified to review that. And I'll also point out that as somebody who's worked for Toyota and done the Plan Do, Check Action, Original, Deming Cycling Quality Control, I am more than qualified to look at any plans and actions that are being put in place. I think at least then we would have some information before the meetings, so we could prepare some questions, and I think people will be happy with that.
So I would take corporate advice on this back from the CCG, but there is something about the fact that we prepare papers that go out in public that give everybody the opportunity to feed into those. They go out at a point in time that our governing body members get that information at that point in time, and they read them and bring questions back. It might be something that we want to do with Ashby Civic Society to bring them into the citizens panel that we're setting up for the STP, so that there is a mechanism by which we can do that. I think if we set something up that's very, very separate for the Civic Society, then we run the risk of it being out with our normal processes, and then it skews what we're trying to do, or it doesn't get done because it's not part and parcel of the normal process. So I think you need us to try and engage the Civic Society in the wider STP agenda.
I just really want to kind of come in because I go to a lot of these meetings as trying to kind of be a bit of a patient representative, and I really do want to try and kind of have a chat with you so I can really get to grips with some of the kind of the concerns that are mirrored across the county. And as far as kind of the board papers and all that kind of stuff, I get them, the public papers. So as far as kind of sharing them, I don't think there's an issue with that. So I think there's potentially a lot of kind of bridging I might be able to do for the Ashby for the Civic Society around certainly kind of keeping you informed and involved, and also potentially if you do have burning questions, I can offer a way into the meetings for that to be raised.
We just want answers. We don't want long board papers and lots of statements. We want to see that the 106 discussions are sorted out with the district council. We want to know what are they doing about outpatients. Give us a document on the outpatients of Ashby, and so the GPs can put a list up on the wall. Here is what we can offer. Here's what we don't offer. That's what we want to know. And why are patients still being transferred from Derby to Lichfield and some even as far as Market Harborough? None of them want to go places like that. So that's the answers that we want. Thank you.
I'm going to drop some initials into this conversation because they've not been mentioned yet. PCN's Primary Care Network, and clearly what you've got there in Castle at in Ashby will be part of a primary care network, who, according to the government and indeed papers we've had here, will be providing a much broader range of services for local people. Have you inquired of your primary care network, I'm going to ask, because that's another avenue you might look at, because that's part and parcel of what's now being organised and set up across the whole of the country, not just Leicestershire. Brenda.
Thank you, Chair. Mine's really just a point of clarity. I don't know where we've parked the S106 money that is there at the moment. Is that part and parcel of the recommendations that you've got? I think it needs to be. I think we need some answers as to where it is, why the NHS hasn't claimed it, and there is a timescale to this. If it's developers' money, if it's not used within a certain time, it'll be taken back. So I think that's a part of the recommendations that needs to be on it. Thank you.
Part of the problem, of course, is that, again, it's multi-agency here because we're talking about what North West Leicestershire District Council are doing with that money. I mean, clearly, you've asked that question. I have the same questions down in Market Harbour area.
Yeah, but it is the
I'm always
responsibility of the
chasing
Health
what's happening.
Board to request the monies. So actually, it's not multi-agency. In 2015, these people here could have requested £500,000 for an initiative.
Yep.
And the other issue that perhaps we haven't discussed in this room is what happened to the money from the sale of the hospital? Was that ploughed back into community health services? Because one thing that we were told at the time was it was to supply laptops for nurses. So what happened to the money? Because it sold for £500,000 hospital. So you know, there was £1 million available for community health services in North West Leicestershire, and yet we still haven't got our services. Where is that money, and what has it been spent on?
Yeah, you've mentioned North West Leicestershire. Section 106 money, the way I understand it, I'm not a district councillor, I'm only a county councillor, but the way I understand it, with the work I've done in the Harbour area, should be spent on the area where it is most needed for. So when you mention North West Leicestershire, yes, but it should really, if it's raised in Ashby, it should be spent in Ashby.
Yes, exactly, correct. I think that's the point that I'm making. You know, I've followed, I'm also a town councillor in Ashby, so I've followed the Section 106 monies with interest. Fortunately, none of it has been given back to developers as yet, but quite a proportion of that money could be sent back to developers if they request it. And I think it's crucial that we have people here telling me of historical data, telling me they've got an evolving process and plans and etc., when there was approximately £1 million that could have been spent on services. And I think that's a lot of money that could have saved a lot of grief. The Castle Medical Group building has been half empty for a long time. We had a one-stop shop. It was the community hospital. It wasn't just about beds. It had a physiotherapy department, it had chiropody, it had outpatients. Yeah?
Only thing I was going to say was, I mean, there's a good question, lots of good questions, but a key question there. What has happened to the sale of the community hospital money?
Okay, so there's some strict Department of Health guidelines in terms of what trusts can do with that money. Some of that money went back into our capital plan and absolutely has supported our workforce to become agile, so predominantly used for the provision of mobile devices that our community nurses, therapists, staff can use in the community. I can't stress how vital that equipment has been in supporting them to be more productive and efficient, particularly in more rural community areas. It stops them travelling back to a city base to pick up their work.
As I said, I'd like to thank everyone for coming. Are you happy, members, of the proposed decision I read out earlier? I've just added one extra bit about, obviously, about the point about Section 106 that Brenda raised. Yeah. But if you're essentially raised with that, that's what we'll push through for the next, effectively our conclusions of today. Okay, thanks very much. There you go. And thank you very much for those that have come all the way from Ashby de la Zouche. Nice to see you. We move on to the man himself. Here he is. Item 9. Right, we'll move on to item 9, thank you very much. So if you clear the room, if you are leaving, please do, but otherwise we are moving on with our agenda. Item 9 is this time of the year, every year, each committee goes through the effective financial strategy for the next 2 to 3, well, certainly the next year, but we like to call it medium-term financial strategy, so it theoretically should be lasting 4 years. And today is the turn of the health area to be looked at, or public health, really. So you should have on your, we have had a summary of the process that we're going to go through. Which is, again, same as every year. We go through each section bit by bit, allow questions, get some answers from the Director of Public Health, and then move on to the next one. So I invite Mike Sands, the Director, and also, of course, Lee Brecken, our lead member, to introduce the paper, and then we'll see how we go.
Yeah, thank you, Chair. Can I also introduce Sam Barrett as our Finance Business Partner for Public Health, who's here in support of the paper too. As you said, the purpose of this report is to provide information on the proposed medium-term financial strategy as it relates to public health, and for the committee to consider any issues as part of the consultation process and make recommendations to the Scrutiny Commission and the Cabinet accordingly. The first bit I'll draw your attention to is paragraph 5. Members that have been on scrutiny for a while will probably begin to recognise this paragraph because it's been around a little while. So we still don't know how public health is going to be funded after April 2021. We've been saying this for a few years now, so every year I come and say we don't know we're funded after 2019, 2020, etc., etc. That still stands. The grant's been extended for a further year, so we've got a public health grant in place for financial year 2021. The expectation is that after April 2021 it will be funded by retained business rates, but clearly until such time as the government kind of moves on that, I can't say for certain, A, how will be funded, whether the grant will be extended or whether it be retained business rates. I can't say what the responsibilities would be after April 2021 because clearly there may be some negotiation around new statutory duties that would come with a change in funding. And nor do I have any clarity at the moment around what the quantum of funding would be, whether it be from the grant or from the business rate retention. So it does make the sort of medium-term financial strategy over 4 years slightly complex, and what I've really presented, I guess, is a kind of roll forward of last year's for a further year, pending a discussion about quantum of funding responsibilities, etc., etc. More positively, the Chancellor did announce in the spending round last autumn, the autumn spending statement, that the public health grant for 2021 is expected to go up by inflation plus a 1% real terms increase. I've yet to see, for every positive there's a caveat, I've yet to see that confirmed in terms of the pounds, shillings and pence allocation circular letter. The latest that's ever come out before has been December the 21st. It's now obviously January the 14th, 15th, whatever the date is. And we've not had the circular to confirm next year's money, so we'll still assume that it's inflation plus 1%, but until I see the circular, there's always that element of uncertainty. But the conversations I've had with Duncan Selby as the Chief Executive of Public Health England have been very positive, both in terms of the expectations around the public health grant or public health funding post-April 2021 and then the settlement for next year. Just for good measure, there's a debate around if you get inflation plus 1%, does that mean that there'll be a number of new burdens like the last year of the Agenda for Change pay rise that we'll have to pay pay for within that. So there's been a bit of debate about would an increase then be wiped out by burdens, but the mood music I'm picking up is still positive that we'd have a small uplift, whatever burdens may come our way for next year. So continued uncertainty, I guess, really in terms of what happens around post-April 2021, and then a little bit of uncertainty, I guess, in terms of next year, which I'm assuming will be clarified within the next few days. If you do follow the LGA Twitter account, I know the LGA put out a tweet earlier on today calling for government to confirm the circular for next year's allocation as soon as they can. In terms of the revenue budget, the one thing I always stumble over with this is Table 1, which I'm hoping Sam will now bail me out in terms of the year-on position. So Appendix B, the proposed growth I'll deal with in the future section, as is the proposed savings Appendix B, which comes to just shy of £1 million for next year. And that's set off by the first two lines, and I never know what they mean. Sam, help me.
So the first two lines, so we'd start with the original budget, and then we have our budget transfers and adjustments that occur in year, a positive figure increasing the budget, and then we add in the proposed growth and take away the savings, and the negative figure that we end up with for the budget is savings that are made within the department to facilitate spending elsewhere within the authority on health-related matters.
So that's a combination of the reduction in the grant. Oh, no, doesn't work out, does it?
No.
I'll trust your judgment. The important bit being is what, £665,000 down on last year overall. Yeah. In terms of Table 2, our net budget, very similar to previous years. I think members hopefully will be familiar that those services that we externally commission from other providers, notably the NHS, so sexual health, health visiting and school nursing from LPT, Children's Health, 0 to 19, and substance misuse from Turning Point, account for something in the region of 2/3 of our budget. So we've got 2/3 of our budget tied up in just 1/3 of the budget lines. Everything else, be it information advice services, services that support community capacity building like local area coordination, lifestyle services like Quit Ready, programs of work around suicide prevention, physical activity, food, you name it, comes from the remaining third budget. So this is the nature of the kind of commissioned activity. That's not really changed an awful lot over the last few years because I suppose it is what it is. We've made significant savings across all the budget lines. And indeed, we'll come on to future savings plans as well. But I guess we've shared them out fairly equally across those budget lines. So the percentage, if you like, in terms of what we spend public health on, remains the same. I guess over the years, we have moved into a more lower level of prevention. So supporting council-run services, again, like First Contact Plus and local area coordination, is part of a deliberate move to try and support people as early as we can and, frankly, as cheaply as we can, where it matters most in people's communities. So not an awful lot others to say on paragraphs 5 to 14, so I'll pause there.
Lee, is there anything you want to add at this point?
No, I think it's a tight budget. I think we know the position from County Council. Obviously, public funding, it's best value from the public paying. So I think that continues through public health, and we await confirmation.
Okay, thanks very much.
Shall I cover growth then? Shall I move on?
Try the next one.
Yeah, so an easy one. Again, PrEP has been there for a few years now in terms of anticipated growth. So PrEP is a new on the market retroviral drug for HIV, so given prophylactically to HIV, those groups at risk of developing HIV. There was a big debate, members may recall, about 2 years ago about how the cost burden would fall if the local authority had to pay for the cost of drug treatment, the drug itself. That would have been a significant cost pressure on the budget. It would have been about £1 million for Leicestershire. NHS England have funded that centrally, but there is a small additional cost of public health grant because we would expect to see more testing for HIV as part of that sort of treatment regimen. And we predict that cost would rise from about £20,000 next year to about £40,000 in 2021/22. So last few years we've had the 40 grand in as a growth bid because we've been expecting it to be rolled out a little bit earlier. That's been delayed, but we've got it in there because I think this year we'll finally get around to rolling out prep, so we will have an increased cost pressure. As it says later on in the paper, to some extent, the bits I can't control, which would provide an in-house, an in-year cost pressure, is around those services we've got that are demand-led. Sexual health is an obvious one because if you have a sexually transmitted infection, it's open access and you can rock up and demand treatment because it's an NHS service. But we deal with that separately, but in terms of planned growth, it's just the PrEP testing costs at 40k.
Same question. Anybody got any points to raise about this single growth item? On to the savings.
Yep, so savings, again, in terms of savings, paragraphs 18 to 22, you'll have seen these before because they were in last year's, and I guess they are proposals that we put forward a few years ago now, which we've then worked through the list, and we're now getting into delivery of those savings. Paragraph 19 details kind of the remainder of what's left of the early help and prevention review that was done in 2016. So members may recall we commissioned an external firm, People 2, to do a review of prevention services across the authority, both children, adults and public health. And they made a number of recommendations around how we could save money from that service offer, which we've been implementing over the last few years. We're in the final year of delivering the savings from the commissioned service bit, which I think in total came to about £1.5 million, of which the review has left us 350k to save in 2020, rising to 515 by 2022-23. And I'm looking at those thinking, I think we've considered most of the individual service lines. So the new model for homelessness prevention, I think came to scrutiny as part of consultation, and it went to Cabinet at the end of consultation at the back end of last year. So we're currently about to go out to tender to procure the new service, the new model for homelessness prevention services, with a view towards having that in place by 2021, April 2020. It might slip a few months, I think, on that one, but that will save us £200,000. Substance misuse treatment services, it's not a new model, but we're bringing together 3 separate services, 2 which are in public health, 1 was in adults and communities. And again, we took a paper to Cabinet in December just to OK that model, which we'll have in place for April 2021, and that will save us a further 150k on our substance misuse delivery, in addition to the £625,000 that we saved from Turning Point when they won the tender, when Public Health recommissioned that element of the service back about 2-3 years ago. So I'm very confident that 350k will be delivered. And then we've got sundry other bits. We're reviewing, and I think we come on to it, the Younger Persons Tobacco Control Programme that we commission. I think we can probably deliver that more efficiently in-house through the Healthy Schools Programme, which would save us 80k next year. And then there's a small contract within adults and communities, which will stay within adults and communities, but because it forms part of the Early Help and Prevention Review, which I'm the senior responsible officer for delivering, that 19k sits as a public health target. And again, I'm comfortable that we can deliver that through decommissioning that service. It does leave a figure of £66,000, which is a gap in terms of delivering the entirety of the Early Help and Prevention Review. In year, we've kind of covered that through budget underspends. I'm sure Maggie's got a question you'll ask me in a minute in terms of how we'll do that, but I'll save my answer for when you do. Paragraph 20, it talks about redesigning integrated lifestyle services. We've done that. That's the weight management service that we brought in-house from LPT, and it's now co-located with our smoking cessation service. We delivered the first £20,000 of that last year, with the remaining sort of full year effect, the extra £45,000 to be delivered in the next financial year. That service on January the 2nd has now redesigned all its materials and is open for referral. So again, we've done the work, and we'll recoup. We'll reap the benefit in the next financial year. Staff absence, small corporate target £10,000, just reducing our sickness absence down to the corporate level of 7.5 days a year per member of staff. Last figures I saw, we've got that down to about 6.47. So again, we're well on the way to reducing our sickness absence by about 2 years compared to what it was 18 months ago. And then the last thing that we're doing currently is a big sum of money, £500,000 from the school nursing and health visiting contract. Again, I said it's delivered by LPT. We negotiated a contract variation last year, We've been in negotiation with LPT about how they would change their operating model, so more use of digital to enable them to freeze their recruitment and save the money in that way. And again, that's well on the way to being fully implemented for April of this year, 2020. So that's the kind of list of where we're up to. So a small number of programmes, but some quite large savings there. Shall I just cover paragraph 23 before we pause for questions? And then in terms of savings under development, there's a few there again. Understanding and managing risk has been a separately commissioned programme, that £19,000. I'm going to bring that in-house as part of my programme delivery team to save that money. Substance misuse, again, has been separately delivered by GPs, but I think we can do that better. Alcohol brief advice, that's where GPs would say, are you a drinker? Have you thought about getting advice? And again, I think we can do that through the programme delivery team. And the schools traded offer really is where we currently deliver stuff for free through Healthy Schools. I think it's appropriate we consider how schools may want to contribute to the cost of that service. A lot of other areas have either decommissioned the service entirely or do charge for it, and I'll be looking to see how other places do it.
Any questions on that particular section? You've got one. Yay.
Well, not to spoil Mike, you know, because he was anticipating my question. It's regarding the £66,000 gap, really, and really some idea of where we're going to get it from, really.
I know you mentioned it earlier on, so I did give you time to check an answer, which I'm grateful for. Within the team, we have the programme delivery team. So there have always been a small number of people, mainly women. So they're the people like Connor that do the suicide prevention work. They deliver the Healthy Schools team. It's always been part of my plan that we increase the capacity of that programme delivery team to take on more of the programme delivery work instead of externally commissioning it. Would also enable us to flex what we provide. So where we started doing the starter conversation suicide prevention bit, it was useful to have that resource in-house to deploy. Gone through a few staff changes, so I've got a number of consultants who are retiring or have moved on to other jobs, and that's given me the opportunity to look at the delivery mix within the department, which I'll carry on doing. And in short, if we do get the uplift that we're expecting next year, I'd like to put a bit more investment into the programme delivery team to bulk out what it's able to do in-house. That would then enable me to think about reducing some of the externally commissioned services, some of the stuff we're not doing. So I'm going to put a bit of investment in the near future as part of a kind of team redesign, if you like, in the expectation that we can pull the 66k out because we'll be doing it in-house rather than externally commissioned. So early thoughts, but I'll work on that early part this year. I mean, I think we'd achieve it anyway because we normally have a bit of underspend grows, that comes in, but it's better to sort of have it in a planned way, and that's what we'll do.
Michael, yes.
Thank you, Chair. It's more of a kind of question around. It's always a question around kind of what does this mean for people who use the services? What's the local implications? And there's also the question around how are you trying to make sure that you're not having a cumulative impact on on service users, members of the public who rely on this in addition to other services. So it's that kind of death by 1,000 cuts because of your reductions and health reductions and other reductions. What kind of analysis has been done to ensure that that people aren't being cumulatively impacted because public health are doing one thing, social care are doing another, and NHS are doing other things as well as everything else that's happening under Better Care Together / whatever.
Yeah, that's a good question. I suppose internally, what are the things that I've tried to put in place in terms of a target operating model, one of which is more digital and the other is more internal services, because I think that gives you more control and the ability to flex. So I think instead of having, from a departmental point of view, a disparate range of externally commissioned services, having it more in one place does enable you to think about what's the cumulative impact. In terms of joint work with council colleagues, obviously, I work daily with colleagues in adult social care and children's and environment and transport. There's not just the informal stuff, I guess, but we do formally have a joint DMT with adult social care colleagues, adults and communities colleagues and children and families. And one of the things we always said about those meetings is it's an opportunity to at least give each other, ourselves, a heads up in terms of what we're planning if there are service reductions, so we can start thinking about how we mitigate them and we're aware of the impact. At the end of the day, there's less, there's less money. So, I'm not going to kid you that there's not an impact. But in terms of do we try and work out what the cross-cutting effect would be, that's what we do internally. And then a little bit like the previous agenda item, you know, there are a plethora of forums. So I've got public health consultants that sit on CCG boards. We've got the Health and Wellbeing Board. We've got the joint work that we do through Better Care Together. So if you think about the prevention work stream of the SDP, I'm, alongside my city colleague Ivan Brown, the senior responsible officer for that. So I've got forums which I can take the proposals we would do, be it CCG board or SDP. So at least there can be a discussion debate about what we're planning and where does that fit with other people's redesign work. I suppose a good example would be Quit Ready a few years back, where we had a robust discussion with NHS colleagues around the efficacy of the service we were planning. There were some fears that they were expressed that we had to allay, and then of course they've been interested in the service ever since. So I suppose all part of multi-partnership working.
I suppose the question, has anybody actually ever really scoped out what the implications have been with all the cuts that have been happening over the last 5 years? Or is it just a case of it's just that kind of, you have a discussion in a forum perspective? Has there ever been a piece of work to actually try to pin down what the implications have actually been?
Quite hard to answer that. I mean, many and varied. In terms of monitoring, there's the public health outcomes framework. So somebody that would help. Won't answer that question. Somebody would say, well, ultimately we've got the public health outcomes framework, which is in the performance report that's coming up. So I suppose the ultimate judgment is, do I think we've made a difference, positively or negatively, to the health of Leicestershire? Well, looking at the indicators, I can't see any sign it's got worse, and if anything, it's got better. There's national bits of work. So I forget who did it. I think it was the LGA did a piece of work led by the DPH in Hertfordshire, Jim McManus, which looked at the effect of public health transition and the reforms under the Health and Social Care Act 2012, as it related to public health. And again, generally, that's been really positive about the effect that it's had for public health being in local government. And it's that particular piece of work also looked at a national kind of sense of, has it made a difference to the health of the population? Again, there was certainly no negative effects that could be seen. Monday, there was a King's Fund report came out on Monday, which again took a more qualitative analysis or thematic analysis of the effect of public health transition. Again, it was largely positive. So if you're asking me, have I tracked the effect on an individual patient within Leicestershire, that's a trickier one, because we tried to do that through some of the Care Track PI work, which wasn't just about, there was a black data box, stick on your data sets, anonymise it, and then see if you can follow the patient through the journey. And we were looking to build some of the public health services in as part of that work, but it fell foul of a number of data protection and data analysis issues, which we're still looking to resolve. So in terms of individual patient journey, can you plot, make a prevention intervention there or not? Does it make a difference to whether somebody's admitted to not at the individual patient level? That's an ongoing kind of wish, which I thought we were going to crack with that particular bit of technology, but we need to revisit and do it in a different way. But more globally, am I satisfied from a Leicestershire point of view and a national point of view that we've kept the show on the road? Maybe I'll put it like that, not go any stronger. From the point of view of delivering the services we need to reduce cost base, and has it had an impact on the health of the population? I'm pretty comfortable with what we've done.
Yeah, Amanda.
Okay, I just wanted to ask a quick question about paragraph 22, which is the health visiting and school nursing service, where you're looking at a £500,000 saving, and it talks about looking to realise more efficient ways of working using digital technologies. I wonder if you could just go into a little bit further about what's planning to happen. Has it all been agreed? Because I'm assuming it'll start 1st of April, and what impact that will have.
Yep. I've left my laptop over there, otherwise I could crawl up the email. I'll certainly get it in the minutes because it's worthwhile doing it. So we agreed the contract variation. LPT, I trust their professional judgment to work out what do they think they can do differently, and they've shared that with us. Basically means a recruitment freeze, so the money has come out because there will be less staff, but there will be more done in different ways. So there's a couple of obvious ones. Talked about more digital, so it's something like whatever, I forget how many checks you get, but the last one, which is little things like the last check from a newborn would have been done face-to-face without fail. This time around it's more of a kind of an offer digitally of, is this an appointment you want or not? So there's a little bit of kind of looking at making certain we meet the requirements of the Healthy Child Programme, because it is a statutory requirement, flexing maybe a little bit about what that means, particularly in the kind of lower risk areas. There was certainly a more targeted programme for high-risk parents, and that's been kind of rolled into a more universal offer. So it's still there, the support is still there, but the money has come out by not having a separate team doing that particular element. Little things like that. The answer is there's a long, detailed list, which I'd be more than happy to put in the minutes of the meeting and do it that way around.
Thank you, Michael. Right, let's move to the last section, which is paragraphs 24 to 26.
Yeah, so in terms of income and other influences, I talked about demand-led activity. There are some things I can't really change, so you're free to access sexual health services as you go along. So if we had a sudden spike in STIs, that would affect the budget. It's certainly an issue for city colleges. I think they're seeing that, but within the county, rates of STIs, if anything, have kind of gone down lately. And health checks, the NHS health check that you're offered by a GP if you're aged between 40 and 74, again, that's not been an issue because, if anything, performance has been declining over the years. I'd like to arrest that and, if anything, push that back up, because I think it's important that we perform the statutory duty, which is getting 100% of people aged 40 to 74 over a 5-year cycle to attend their health check. But again, that's demand driven, depending on GPs, how much time a general practice got to devote to this, but also the willingness of people to take up the offer of a health check. As I said at the start, there's still some debate around, if we do get this uplift, what might be the burdens that will come our way. And then lastly, in terms of paragraph 26, there are a number of other sources of income which help out the department. Public health grants by far the largest, but there is external funding from Sport England, which goes to Leicestershire and Rutland Sport. Leicestershire and Rutland Sport is hosted by the local authority, and its kind of budgetary responsibility sits with public health. A small element of funding from the BCF, First Contact Plus. There's still, 7 years on, providing a public health service for Rutland County Council by way of a service level agreement. That £151,000 figure is, a vast majority of that is the service and not my salary, I should point out. And for the last few years, we've been providing additional public health support to UHL. So one of the consultants has been on secondment or loaned out to perform that contract. Don't know where we stand next year, but again, that's brought in significant sum of money for about the last 3 or 4 years. And sundry other bits in terms of funding from OPCC for drugs. The CCG's down as extra funding. We don't really make a profit on that, but that's more about, it's a long story, depending on if you're a woman, whether you have a coil fitted for contraceptive purposes or heavy menstrual bleeding, different people pay. So the CCG would pay for the menstrual bleeding, we would pay for the contraceptive coil. It made sense to say, let's not bother GPs going, if it's that, you've got to go and bill them, if it's that, you've got to bill us, give us the money and we'll sort it out. So there's no profit in the 140k, but from a system and a patient point of view, it makes an awful lot of sense.
Thank you very much. Have we got any points to raise on the last section there? Yes, Maggie. Yeah.
Is the external funding already confirmed, or is it an assumption?
That's a good question. It's an assumption. So, hence UHL's an amber, because we're still yet to hear if they want to carry on the support they've done. We've put green down for Rutland. I'm assuming they're not going to ring me up and they'll go, no, we've had second thoughts and we're going to get it from Peterborough. So, to be confirmed, but the green, I suppose, reflects a level of confidence for some of those.
Yeah, I think Rutland are worried about how they're going to spend all this money on pheasant bites or something in their local McDonald's.
Don't go there.
Apparently, according to the Duchess. Okay, thank you very much, Mike. That's anything else? Anyone else comments over there to make? Oh yeah, the recommendations. Have we got the recommendations this time? No, we haven't. Have we? Nah. Normally do, you're right. Right, must be on this. Okay. Yeah, the recommendation is that we've discussed and seen obviously the MTFS for public health, and we note them and we're okay with it. Yep. We're okay with that. Thank you very much. So we move on to item 10. I'm desperately trying to finish by 4, but we'll see. This is Michael, who's going to talk to us about Health Watch Leicestershire report on medication management. Just to say that we've also got Claire Elwood and Anthony Oxley. Claire is from the head of pharmacy at UHL. I used to know you, one of your predecessors. And Anthony is from LPT.
Thank you, Chair. I'm not going to kind of labour the point as far as the report's concerned. I just kind of set some real context and just to kind of explain what we've kind of identified as far as the report's concerned. So when it says medical management, it's more about the experience that a patient may have in a hospital setting versus through a discharge process, what they would then face when they would go for a repeat prescription at their GP practice. Now, this was something that we identified as an area of focus because of we were getting more than just the occasional member of public raising the fact that they would come out of hospital, they'd go to the GP practice and they were facing issues of one type or another, and then trying to get access to the medication that they had been told by a hospital clinician that they needed, and in a patient's mind that sets an expectation that this is what I need, and then to be told by another clinician, well, actually no, you can't have it, it causes undue concern. And we wanted to try and firstly appreciate whether or not was this a very infrequent issue, or was there a larger issue at play. So we've kind of through actually attending kind of outpatient clinics and GP practices, actually approached members of the public and just asked what their experience was. Had they come across this, and if they had, what had they faced? And just allowed us to try and then kind of build a better picture and a better understanding of what that issue was. So the report that is presented today is a very kind of light touch summary of the findings. If you want a copy of the substantive analysis report, then I'm more than happy to provide it. But given the fact that we want the documents to be something that is publicly digestible, we've tried to kind of make it as concise as we can do. So I think it's worth just pointing out that as far as the initial hypothesis, I suppose, kind of as to why we started this piece of work, it didn't identify that there was a significant issue faced by patients that were leaving hospital and having to access repeat prescriptions in their GP practice. So it's nice to kind of ask a question and to find that we're not looking at a significant issue. It has identified just a couple of findings that we've kind of highlighted as far as the kind of communication between the hospital and the GP, and I think that kind of replicates quite a common issue that we do here around communication between one part of a system and another, and that is a much bigger issue, and actually something I believe our colleagues in Healthwatch Rutland are looking to do quite a focused piece of work around, but also identified just a recommendation about how much medication may be given to a patient on their discharge. But again, it's about just trying to put the patient opinion in front of the relevant people and say, this is what people said. So,
comments. I mean, on the basis that one of the recommendations is looking at improving communication. I mean, I imagine all GP surgeries surely have now got links in communication. I was a bit surprised that there might still be a problem. I mean, and again, this is probably local, although I did see the word harbour in here as one of the districts that's a bit dodgy. My local health centre are now taking quite a long time to do repeat prescriptions, and I do them all online. I expect them, within half an hour someone will press a button and it's at the pharmacy. Now, pharmacy now has a large sign up saying, please don't expect your repeat prescriptions to be here within 7 days. That would be quite a worry if I was given a chit from the hospital that says, here's your medicine, but every last 7 days you've got to get an appointment with your doctor to get it all sorted. So, I mean, it's not the hospital's issue. This is obviously further out in the community, but it just demonstrates, I think, why these timings are quite important. Anyway.
It might be helpful for me to just outline what the current practice is from UHL, and I guess a little bit about how we're looking to work together. So obviously this report covers both outpatients and the discharge from hospital. So with the TTOs for discharge from hospital, I'm confident that the documentation on discharge is getting to GPs quickly. Our standard is 24 hours. They are electronically transferred, and I think for both UHL and LPT, that is audited and that is happening. From a UHL perspective on discharge from hospital, what we should be doing, and certainly from anything supplied by pharmacy we are doing, is ensuring there's a minimum of 2 weeks supply at the point of discharge. That isn't that we will necessarily supply it. So if we have a conversation with the patient and they say, I've got a full repeat prescription at home, and that nothing has changed, we will not supply. If anything that we do supply whilst they're in hospital, we supply a patient pack, which is normally a month. So that's why there is some things in here about patients potentially going home with more than a month, because if they've got a week and they say, I've got no more at home, we'll then supply a further month on discharge. So a lot of our supply is around trying to ensure we don't split packs as much as possible, because it's inefficient and it can cause confusion for patients if you're supplying a lot of medicines in white boxes. So on discharge from hospital, what we should be getting is a minimum, we should be ensuring there is a minimum of 2 weeks available from whatever source that may be. The only area where I think it can sometimes go wrong is where patients are discharged late at night or out of hours, and sometimes even from the perspective of the patient, or I suspect sometimes from nursing, there's a bit more of a, I'll just take with what I've got rather than wait for pharmacy to supply medicines. And I think the best way we're dealing with that is actually all the work we're doing on trying to get medicines prepared earlier in the patient's stay and get patients out of hospital in daytime for a multitude of reasons. So I think for discharge, what we've got in place in terms of ensuring a minimum of 2 weeks, I think is reasonable in terms of keeping patients, supplying patients' needs, and also giving appropriate time for GPs, because we're absolutely assured those discharge letters are getting there in time. I think for outpatients, it's slightly different, because we're always making a fresh supply. We're not looking at what a patient's already got, because for outpatients, we'll only supply new or changed medicines. And again, we will automatically, for anything that is likely to be continued, make a month's supply, and that again relates to patient pack dispensing. I think where there may be some issues is supply from the emergency department, where we'll often give a shorter duration, and that's because there's less predictability about the patient. I do know there are some challenges around outpatient prescriptions getting to GP practice, and that might have been partly reflected in this report about people struggling to get medicines from their GPs. And I know there is work within UHL around improving the timeliness of outpatient letters. I guess the final comment for me is the requirements around the NHS contract for outpatients is that we only supply medicines that are urgently needed. I think nationally that's often interpreted as needed within a week. We've had a lot of discussion within Leicestershire and with our CCG colleagues that actually that's probably not particularly helpful for Leicestershire right now in terms of access to GP surgeries and in terms of speediness of getting information to GPs. So we are proposing that we look at supplying anything that's needed within a minimum of 2 weeks, which I think is more realistic. In reality, my experience at UHL at the moment is we are more often than not supplying whether it's urgent or not, but that's not necessarily 100% consistent. And then a final comment for me, before there's any further questions, would be there is a piece of work ongoing at the moment between 3 CCGs, UHL and LPT, looking at revising our prescribing standards across the interface, and these issues about at what point do we supply, how much do we supply, so on, are being actively considered as part of that, and that work is progressing, and we're quite close to hopefully finalising that documentation. Once that's finalised, then that's the ideal opportunity for us to go back out to all of our prescribers, our consultants, and making sure they're absolutely clear on the expectations. Because one of the questions for me from this is, despite what I've just described, is there some inconsistent practice that we need to get rid of, to iron out? And I think having that document finalised between the CCGs and the two of us will be the ideal time to go back out to our prescribers and really reinforce what we should be doing. And that may address some of the things that have potentially caused the results within this report.
I'll just add a couple of things from LPT's perspective. I mean, our standards are very similar to UHL's. It's 14 days minimum for discharge and 28 days for outpatients. It's fair to say we get audited on that regularly each year by our CCG colleagues, and there's been no problems identified by those audits, certainly for the last 3 or 4 years that I can recall. And it's probably also worth mentioning that I think our standards are in line with or better than other areas of the country. I'm not aware of anybody that routinely gives more than Leicestershire quantities on discharge, certainly, and in some areas only give 7 days, which we have not done for a long time. So I think comparatively to other areas of the country, we stand up well to our colleagues, yeah.
And you also do letters to the GPs and everything else? I mean,
Yeah, the discharge prescriptions from both LPT and UHL are pinged across as soon as the discharge letter is generated. It goes straight across to the GP within 24 hours. Now, again, that's regularly audited by our CCG colleagues, and I think it was being done monthly, but that's just been stood down because the compliance was so good, basically, yeah.
Any other comment I would make is we do have a forum, what's described a transferring care safely group, where complaints from GPs about UHL and UHL about GPs can be discussed. There are some issues around particularly duration of supply and where we perhaps haven't supplied when we should that come up through that. So those are worked through as well. So there is a really quite an active forum where these are discussed. I also, just to note, I mentioned there was something in the report about a patient perception that there were prescribing decisions based on cost and GPs not prepared to carry things on through to cost. Now that's disappointing because actually we all worked the same formulary across UHL and GP practice, so there shouldn't be any situations where patients are started on something within secondary care and GPs are not prepared to continue it. It may be that secondary care should have taken the ongoing prescribing responsibility, but we certainly shouldn't be in a place where there is a different expectation on what is affordable. And obviously if those issues arise, then we will be following those up.
It was to do with branded and all that stuff. Yeah, hospitals uses one brand and GP uses.
That's possible, but the hospital choice is always based on the cheapest. Sometimes that's branded, but yes, there may be some issues around patients wanting branded, but certainly there shouldn't be an argument around what can and can't be used.
Brenda, yeah.
Thank you, Chair. The answer to what I'm going to ask might have been hidden in what you've just said about. You've been speaking about prescriptions. My last experience of a prescription from the hospital is that you have to go and cash it in at the hospital. Why can't you go home then to your local chemist and use that prescription in your local chemist? Is it a funding reason or what?
It's if I'm absolutely honest, it's partly funding, it's partly clinical care. So not all, majority of hospitals in the UK do dispense their own outpatient prescriptions. Partly that is because if we dispense them ourselves, we benefit from both not paying VAT, which is the same as a community pharmacy, but also we benefit from the prices that drugs are sold to the NHS, which is different to the prices they're sold to community pharmacy. So for some drugs it's not very different, but for some drugs there is a significant price increase if it's obtained from community pharmacy. So it's actually much cheaper to get it from UHL, and that is I guess that's the financial rationale for why we will frequently supply our own prescriptions rather than give a prescription that can be used in a community pharmacy. The other side of it is if a UHL consultant writes a prescription for community pharmacy and there is any problem with that prescription, there's very limited changes that the community pharmacy can make to it. Whereas when they're dispensed within UHL, if there is any problem with that prescription, then we will directly contact the prescriber, and because it's an internal prescription, we can make amendments to that prescription. So we will, for example, change the duration. If it's only been supplied for 7 days, we'll change it to 28. We will challenge the dose. We can access clinical information about the patient. We will, if necessary, change the brand. Often those prescriptions are not accurate. One of the big problems with hospital outpatient prescriptions at the moment, which I would like to change in future, is they are handwritten. And that does create some real issues about the quality of them, which is very different to a GP where the prescription is always accurate. Not necessarily right for the patient, but it's accurate because it's electronically prescribed. And at the moment, when we look at the quality of the prescriptions that go to my pharmacy, if they hit a community pharmacy, there would be some real challenges which would impact on the patient about resolving those problems on those prescriptions. Now, that's obviously something we need to tackle, but the most sensible way to tackle that is to put in electronic prescribing for outpatients, which we don't currently have. But that wouldn't change the fact that for Leicestershire it is more economic for those prescriptions to be dispensed within UHL. One of the things we are urgently looking at as a trust is how do we make that more in line with patient needs. So how do we make it easier for patients to get prescriptions without having to visit UHL? And that's things we're looking at is should they be able to collect our prescriptions from Loughborough Hospital, for example, instead of having, particularly people got repeat prescriptions, instead of having to go to UHL, how do we do more prescriptions delivered directly to the patient's home? So we are aware that that is something we need to look at to try and make it as much as possible. I do not want to bring any patient into UHL who doesn't need to be in UHL, and collecting a prescription is clearly not ideal.
My husband has got prostate cancer, and he had to wait for the prescription after being told, and it wasn't all in, so they had to make a special trip back to the hospital at the end of it. So I mean, that obviously isn't an ideal situation, but it coped with it all right. And that's because we've got a car and the transport was no problem. But I'm quite shocked that there is a difference in pricing. I would have thought NHS, you know, the playing fields would have been level here. And I'm shocked that there is a difference between community prescriptions and the hospital prescriptions. And historically, why is that?
It's been the case for forever. I mean, I think it's the prices for a community pharmacy is set by the government essentially, and it's the price is set down in a document called the drug tariff, which tells basically anybody who wants to know what a retail pharmacy will get paid for dispense for that particular item on a prescription. Now, how those prices get derived is lost in mystery, and there are certainly products where we can buy them for like £20, where a retail pharmacy would get paid £80 for it. And there are some arcane rules, but it's like I say, it's all done very centrally. It's not a local decision at all. But hospitals, we work in consortiums, and we'll purchase drugs at the most appropriate price, subject to quality, etc. And that will often be quite significantly below the drug tariff price. And obviously, it would be foolish for us not to do that and spend money that we didn't need to spend.
Just overall, it's all a cost to the NHS, isn't it?
Yeah.
And so I'm still shocked actually, and surprised that it's not. I don't know. I'm shocked. We'll park it there for now.
Just coming back on your specific points about waiting times, and what we do is we audit our outpatient waiting time. So what I can currently tell you is across all 3 of our outpatient dispensaries are 95% of our prescriptions are dispensed in less than 20 minutes, and that's the kind of target we monitor too. The other point just about availability, one other advantage of getting drugs from UHL is we obviously know what our consultants prescribe and we keep those drugs in. If we sent a number of our patients to community pharmacies, they would not have that drug in stock because a lot of them are quite specialist drugs. So that is an issue. And I'm not sure what may or may not have been offered to your husband, but certainly my expectation of my outpatient pharmacies is where we are inconveniencing a patient because we cannot get hold of a drug, is that we will offer to pay for that to be delivered to their home, and that should be what we understand. But I recognise we need as a system to find a better solution to how we avoid patients attending UHL to collect a prescription. That's not the service I would like to provide, but the financial imperative at the moment means that we need to find some solutions, and that's part of our kind of work plan as a system that we need to address. But the cost right now of moving entirely to community pharmacy prescriptions, notwithstanding the clinical issues I've raised and the supply issues, is unaffordable.
So the prescription's gone missing. It's then where do you start? Where does the patient then start, if they're an outpatient particularly, to go back and trace that back? Because if they've lost the letter and the trail and they've been discharged, how do they get back into the system to get the medicine that they need?
So it's not the prescription that's missing, it's about a delay in the clinical letter going to the GP, which then makes it difficult for the GP to prescribe because they have not necessarily clarity on what to prescribe. If things have gone wrong, the options really available is for the patient to seek support from a GP surgery in following that up, or through the consultant secretary in following that up. But it should never be lost. It's just about checking whether a letter has been generated and ensuring that letter is then copied to the GP. I'm confident they are going to the GPs. I believe there is, in some areas of the services, they're not as timely as they should be, and that is active work that's going on to address that. But there's no sense of prescriptions going missing as such. It's about timely access to health information to allow the GP to prescribe, and that's one of the reasons why we are saying it wouldn't be appropriate for us to ask GPs to prescribe urgent items after an outpatient appointment. It's important that we make a supply to allow time for that process to then happen.
Could I just add something very quick from an LPT perspective? One of the things we're doing is we're moving over to using System 1 as our patient administration system, which is, I know it's, I share your twinge, but it has the advantage of being the same system that most GPs in Leicestershire are using. So if something does not quite seem to be where it should be able to be seen, then the GP should be able to see it in System 1 as well. So that sharing a common system with primary care will mean that those issues where things get lost in translation should be reduced, yeah?
This isn't working. It was only a personal experience because it's happened to my mum. She went into hospital. We've come to the point of the repeat prescription. The GP said, "Oh, it's not here. We can't do anything about it. You'll have to contact the hospital." My mum's elderly. She's thrown the letter away. Where do I go? Where do I start? It is difficult.
I know. I was just going to make reference when the point was made around the kind of the disparity in prescription. There was quite substantial piece of work done with the CCGs to actually take out the ability for certain prescriptions to be made because you buy them for 20p on a counter when the NHS gets charged several pounds for paracetamol. And just the kind of medication and pharmacy is quite a it's an issue in and of itself, and then I think it was just interesting that this was something that kind of came out of the work that we've been doing around kind of the patient experience around discharge. So it is quite boggling the mind sometimes what that some of the experience is. And just kind of going back to the point you made around the public perception around kind of prescription and budgeting within a GP sitting. Rightly or wrongly, and I wouldn't want to comment if this is something that is real or not. There is a real sense within members of the public that there is a cost cutting of if a GP practice doesn't spend it in a prescription budget, then that budget is then fed back into the GP practice. I don't know if you're able to comment on that or not, but that is something that a number of people do believe.
We've got a CCG colleague in the public gallery who's shaking his head because we can't really comment on secondary care, but Vishal's implying that isn't the case.
Interesting, wasn't it? I mean, some of the stuff there. Really, thank you very much indeed. I mean, I've learned things today. I expect, having worked in the NHS for 45 years, I didn't think I would, but I have. Okay, we'll move on to the penultimate item, almost. This is paper 11, pages 81 to 92 in our packs. And this, I gather, is Vishal Mashru. There we go. There you go.
I'll take the paper as read. However, I'll just go over some of the salient points within that and I'm happy to take any questions that arise. So the purpose of the report is to provide an overview of medicine shortages, processes in place nationally and locally, and how these are escalated across the system. I suppose one of the key bits for us as one of the stakeholders within this, it is imperative that we work together with all of the stakeholders to ensure that the impact to patients is minimised as quickly and as robustly as possible. And I share that our NHS colleagues in NHS England share the same view as well. Just going on to the reasons for drug shortages, so there's within Appendix A, there's a more detailed analysis of some of the reasons for the shortages. However, the four main shortages and the reasons behind these are manufacturing problems, supply and demand issues, and there's more patient need than is available. Raw material availability, which is quite a common one currently, and some regulatory issues, which involves getting them relicensed all through the process. Like I said, in Appendix A, there's a more detailed analysis of what is covered. I've also included 4 examples of the most current and common shortages that are in the system at the moment, and happy to take any questions on them at that point. Also nationally, the NHS and Department of Health are key to some of this help and work that they provide. So they're responsible for the supply of and continuity of medicines across the UK. And they've put together multiple different systems and processes to ensure that communication is key, and also patients and those stakeholders are getting the right level of information, and processes are there to mitigate some of the problems that are arising. Figure 1 details the overview of the process, so what happens when there is a shortage of a particular drug or the reasons behind it. There's 3 stages. One is a notification of issue, which comes from either a wholesaler or one of the partners involved, or even patient groups or public members. This is then risk assessed for the reasons behind the nature, the likelihood of it continuing, and then assigned a clinical tier. And then the final step within that is then to provide some options and to ensure that how do we ensure that patients are not affected by some of these problems or issues that are arising. Following on from that, there's a more detailed escalation process, which at one point, if it is a tier 3 or tier 4, which is in Appendix C, I've outlined a bit more of a detailed approach as to the different tiers and severity of medicine shortages. These go to the ministers within the cabinet to have a discussion and review why that might be, and actually escalate some of that process on a more national basis. Tier 1 and 2 are less severe, and they're mitigated fairly swiftly. There's always an other alternative within the system to provide a patient need. In terms of locally, so what do we do locally, and how do we address some of these issues locally? We work really closely with our community pharmacy colleagues. We work closely with our UHL and LPT colleagues as well, to ensure that any response to shortages are mitigated as quickly as possible. They have lots of clinical experience and clinical expertise within them secondary care teams, so utilising the knowledge of the secondary care specialists, we try to put in place a process for how we address this and how we support our GPs to ensure that prescribing doesn't stop. We have newsletters that go out frequently to primary care, to our colleagues around the system, to community pharmacy. Like I said, we're in constant contact with many of them. There's also, for more severe and more urgent medicine shortages, we send out urgent emails or telephone each and every practice. We also have a decision-making software which sits on GP clinical systems, which helps them with best practice, with some sort of guidance around formularies, what's the most appropriate. There's messages on there for the sort of longer-term shortages as well. So, for instance, the HRT, the hormone replacement therapy shortage, that's been quite ongoing. There's a message on there to support GPs in how they prescribe and how they may change some of their prescribing for the relevance of a patient. Anthony and Claire previously alluded to a formulary across Leicestershire, so we have an area prescribing committee called LMSG, and we make, I'm one of the members of that, but we make decisions on what drugs are taken into the local health community. But also we have a process, which is one of the appendices as well, of how to manage this and how community pharmacy can support their GP practices to minimise workload and impact to patients. So there's a real process which is being updated in line with the national guidance to ensure that it's a streamlined process and patients aren't having to go back and forth, which is sometimes the case when things aren't available. And finally, there's partnership working, so we've established lots of partnership working as the shortages started to gather pace, so that there is now more than there possibly ever was. So we're working really closely with our stakeholders and colleagues to ensure that the impact is not significant. At that point, I'm happy to take any questions on the medicine shortages.
Tom first.
Yeah, I fully understand what you're saying, but really, in Appendix A, it seems to come down to commercial practice. The drug companies are really looking for the place where they can get most value out of it. I mean, it's not really the EU's fault, but even the manufacturers within the UK are happy to export drugs abroad if they can get more. I understand that the change in the pound and the euro and everything else affects the ability, and obviously abroad they want to get drugs cheaper, the same as we do, but we have very little impact on that. We cannot do much about that. Just a comment, I mean, your hands are tied. It's not a criticism of you, it's just commercial practice, and that, you know, that is very difficult to overcome. What would you say? Is that correct?
It's really hard to comment on what commercial practice happens within wholesalers or within manufacturers, because we're not privy to that level of information. It is frustrating for us because, you know, at the end of the day, it's our patients that are most affected. And, you know, we try to do the best that we can do, and our GP colleagues try to do the best that they can do in the time that they have with each of these patients. But as these shortages grow, it's really challenging for them to keep on top of it. And actually, some of the communications, it's really challenging to keep on top of the number of communications that come out and the frequency of them. So we try to minimise the level of that, so not to inundate them, because it's important that they're kept abreast, but not continually bombarded. So I think, you know, it's really difficult to comment on that bit, but that's how we're trying to mitigate.
Well, there's little doubt that a company that's a public limited company is going to be trying to maximise returns for shareholders. That's a given. They will do that irrespective of. I fully understand what you're saying, but it is quite a significant impact, and I don't think it's really anything to do with the EU. You're even saying the manufacturers are allocating quotas to try and be fair. That in itself seems very odd, but it is really difficult. I just can't see how it isn't a criticism of you. It's not. It's actually saying I don't think there's an awful lot you can do about that.
Yeah, I think it's genuinely. I mean, I think the only bit that we can really do is to continually keep on top of it, which we do.
Oh, yeah.
We're in constant contact with NHS England and our Department of Health colleague, which is key to this, and you know, some of the EU exit things that planning for EU exit and planning for drugs when that may occur. I think they're just a little snippets of what we need to do and how we process. But yeah, fully on board. Take your point that our hands are tied to some extent.
Amanda.
I've got to press this button harder. Thank you for bringing this report. It's been something that I've been really interested in personally for a little while. The particular area of interest of medicine shortage for me is the EpiPen. I mean, other brands are, well, depends, because that's actually been part of the problem. There's been a manufacturing issue, but this seems to be pretty long term. It's been, initially it was a supply issue, and now there's a you know, obviously an issue with the pens discharging properly. One of the things that I'm really interested to know about, I mean, this gives a really useful overview about what happens. I really would like to understand what the impact is within our services locally. And, you know, changeover of the EpiPen has required us needing new training to have a different method of jabbing my daughter or whatever, if she has an allergic reaction. But I think it's really, you know, I'm really interested to know how else do we, as in Leicestershire, look at that overall impact. So all of our schools will have EpiPen training, as will our care providers, as will nursery providers. How is that rolled out? If there is an ambulance calling for somebody that's suffering from a anaphylactic shock, what's the response? Do EMAS know that there has been a different medication that's been given? And I think it's for me, report is really useful for providing information, but I really want to understand the impact on what happens locally to try and mitigate the risk factors that any one of these shortages could create within the population that needs that medication.
So I think one of the key bits is that the medicine shortages range in different complexities. So you've got your very simple ones, which is a transfer tablet A to B, which is quite straightforward, and you can tell a patient take one a day. You just take one a day of this new one. You get to the slightly more complex ones, which EpiPen or your auto injectors for adrenaline are, and some will require further training. There is that element. With respect to what happens in schools, unfortunately, we don't form part of that training that goes to schools, especially with some of them obviously having their own individual policies and own different protocols within that. What I am aware of is that our paramedic teams and our EMAS teams and hospital teams are really well trained up on not just that one device, but the multiple devices, but also trained up on how to give adrenaline by injection. Now, one of the things that within the documents that we've received is for urgent use or hospital use, they've been recommending adrenaline as an injection form rather than the auto injectors because of the availability. So they've done a really big upskilling on how you use that, how you do that, and how you administer to a patient, because just in case you need to use that method. Similarly, our GP practices have had that communication as to you may want to consider in your emergency bags to carry adrenaline injections rather than your EpiPens if you're unable to obtain them or use them. And clear instructions with how to administer that and how to give that. So that's part of how we're trying to minimise the impact. And I'm not saying it doesn't have an impact, because it clearly does. On yourself, you've had the impact of having to be retrained, family members being retrained, a new device. It's very different in an emergency to remember how to use that particular device is not ideal, because you're used to one other. So the ongoing shortage seems to be clearing up, so we're being told by the manufacturers and having spoken to them not so long ago that there is availability of all of the different auto-injector pens, but it is by calling their manufacturer's line to obtain them. They're not freely available due to just keeping a emergency level stock for patients that are in need at the time.
Thank you, Chair. This is deeply concerning, in all fairness. I think without mentioning the obvious elephant in the room, I think it's disappointing that there wasn't, there was a promise a few years ago from David Cameron about creating a national, almost kind of college or some kind of setup where there would be to tackle the kind of the grip hold that pharmacological companies have around health services around the world. And I think it's a real shame that kind of didn't kind of come down. But how bad is this? Are we talking? Because you've kind of drawn out the top four. So not that these are the 4 ones, but these are just the top 4 that these are likely to impact. So how many medicines are we talking about, and how many people are impacted by this?
So I don't have an exact number on the number of patients impacted. That's probably something I can get, but not have available to hand. In terms of how many medicines that are directly infected that are not available at this present moment in time, you're looking at between 50 and 70. Some are very intermittent, so they're out for a week and then back in. But as you may appreciate, it's quite a changing landscape. So you could have 50 that are unavailable one week, but they all become available the following week because of manufacturing process and availability and obtaining the stock or whatever that might be. So it is quite a changing landscape, which makes it really challenging on the sort of coal face for GP practice and patients and community pharmacy to really keep up to date with it. I was talking to a GP yesterday who said I had a patient when I need to change it, I'll change it to this one, and then promptly found out when he changed the next patient along that drug had gone out of stock. So it's a really changing landscape, and we try to keep as far up to date as possible. We'll get contact from our NHS regional colleagues who provide that level of detail and level of information. We feed that back into them as well, so we feed back the frustrations on from general practice, from patients in our areas, to the frustrations that we have. But unfortunately, there's only so much, going back to some of the initial discussions as to how much influence we have. We can feed that back, but I'm not sure how much further influence we have on the national picture.
I mean, just to have a slight aside, just to reiterate Councillor Barclay's point, I'll just mention Gaviscon and the way that they withheld the chemical compound just to ensure they could get a little bit more money out of the NHS.
Good. Yep.
Could I? Yes, this is a serious report, isn't it? It says that medicine shortages are occurring more frequently and globally for a variety of reasons. What is the feeling though within the NHS about the potential for shortages when we come out of Europe? This was very much to the fore a few months ago, but the issue seems to have gone away. You've referred to it obliquely on page 87, but is everybody confident now that there will not be further shortages, or is it a matter that we haven't got the full picture?
It's hard to have that crystal ball and say that there won't be. However, even with each of the EU exit timelines and each of the previous timelines that we've had, our NHS colleagues have put together a really robust plan as to how we're going to mitigate some if there is shortages, or how we can redirect to different ports and plans in place. I've not seen the current plan because it's not been made available yet, but I'm sure in the coming weeks and months that will become available, and we'll have a similarly robust plan as to how we prevent any shortages occurring. One of the plans was to hold a fixed amount of stock within a UK depot, and that's then available for redistribution should the shortages occur. So there's plans such as that in place for really key items, as well as less key items as well. So I'm not sure we can look that far to know what might happen, but there's certainly robust plans that have been in place previously.
Yeah, thank you. Another example you could have given, of course, is the flu vaccine, which comes and goes. And I know it didn't affect me this year, but I know some people it did affect. They went to the doctor and he said, come back next week, we'll wait for stock. So it clearly is very cyclical. I was quite surprised when you mentioned about the number, though, 50 to 70. Obviously, that's a minor drop in the ocean compared to the vast number, but still, to the patient who is taking one of those medicines, it's an issue, isn't it? Yeah, thank you very much. Anyone else got any questions, points? No? Anyway, thank you very much. That was very interesting.
Thank you very much. Firstly, apologies from Andy Brown. He's not been able to attend today. And Kajal, who's one of the public health business partners, had to shoot off. So just the two of us today. We won't spend too long going through the report because I believe you're probably running a little over time anyway. So we'll take the report as read. The purpose of the report really is to provide an overview of performance issues, which the committee might want to seek some further reports and information, and obviously if there are questions at the end and we're not able to answer them, then obviously we can take those back to our respective organisations. Just to let you know that NHS England have produced a new NHS oversight framework which was issued at the end of August, and this is used by NHS England and NHS E&I for assurance purposes against CCG performance, and I'll outline some of that a little bit later on in the paper. So the paper really has evolved over time, and it does take account of some of the changes that the committee have asked for. Split into 4 sections, so performance metrics against the Better Care Fund, which Philippa will pick up in a minute. I'll pick up the CCG performance and the quality areas that you've asked to be considered, and finally the public health outcomes metrics, which I'll pick up on, but I might ask Mike if there are any questions that I'm not able to answer. So, so Philip will take us through the Better Care Fund position.
Thank you. The 4 metrics currently reported in the Better Care Fund are around permanent admissions of older people to residential care homes. Currently, the forecast outturn for this is to be over plan, but the latest position has improved since this report was actually completed. So we're now forecasting that there will only be 878 rather than the 899 that was predicted last month. The second metric, against the 88% target, we are not meeting that in the latest figures. It has improved for the latest month's provision, so that was 86.5, and obviously social care colleagues are working on trying to improve that. Metric 3 is the delayed transfers of care. This has been quite challenging of late, but for this year we have met the target every month so far. The December figures will be interesting to see. The November figures, which aren't on here, we had 1,162 against a target of 1,286, so we met the target again in November, but very challenging for December, so we shall wait and see when those figures are published. And for metric 4, the non-elective admissions, we are currently forecasting to actually again meet that target, and the November figures again show an improvement of that position.
Okay, thanks. So I'll take you through the CCG performance dashboard. So this is shown in Appendix 2. As I mentioned, NHS England produced a new oversight framework at the end of August, and this really puts greater emphasis on a system performance alongside the contribution of individual healthcare providers and obviously the commissioners, and this is aligned to the 5-year national plan, NHS plan. The 5 areas of assurance around for CCGs relates to new service models, preventing ill health and reducing inequalities, quality of care and outcomes, and there are actually 31 metrics relating to that, so there's quite a high emphasis on that. Metrics around CCG leadership and workforce and CCG finances. So the full dashboard, as I say, is produced in Appendix 2, and that was produced by NHS England at the end of October. The next one's actually due at the end of January, so we've just missed that one. The table from page 100 onwards are really the key constitutional metrics which still stand, and this has been a standing agenda within a standing item within the report, so I will take that as read. There hasn't really been any significant changes in performance since the report that we last brought to the committee. So the 3 metrics that we're concentrating on are 62-day waits for cancer, 4-hour wait for A&E admission, admission, transfer or discharge, and the 18-week referral to treatment. And as I say, within pages 100 to 101 there's some detailed information about what providers are trying to do to improve performance across those areas. On page 102, the committee have previously asked for information on other cancer metrics as well. So the table there shows that. This was October data. We have since had November's information in. There isn't a huge amount of change, so the reds are still red, the greens are still green, with the exception of the last but one, which is around patients that are referred from NHS screening services. They need to receive their first definitive treatment within 62 days, and that's now green for both East Leicestershire and West patients, so that's some positive news. Again, the committee previously asked for information on any never events that had happened at UHL. So paragraph 24 outlines that there have been 5 never events in the last 12 months there. The last one taking place in September, which related to a retained foreign body. Post-procedure. Actions there that UHL have undertaken include review the safer surgery checklist, and I believe that the patient's parents had also met with the trust to obviously express and discuss their concerns around that. I do like to pick up some improvement areas because it does feel as if it's all a bit negative sometimes. Paragraph 25, diagnostic 6-week waits, that's still being achieved at UHL, and actually both CCGs are the highest performing quartile across England, so that's good. There have been no 52-week patients waiting at UHL for 16 months now. However, there have been some in out-of-county providers for UHL and West Leicestershire, and they've mainly been, we've had some down in London, a couple I believe in Derbyshire, but certainly none at UHL. The other area I just wanted to mention, East Leicestershire, again in the highest performing quartile for the number of clinical staff working within primary care, and again that's a metric that's picked up in the new oversight framework. So just a quick mention on future reporting. So we are expecting some quite significant changes from the new financial year, and the new metrics are likely to be even more aligned to the long-term plan. And obviously, as we come to future committee meetings, we'll try as much as possible to mirror that new framework. But also to let you know that NHS England are currently trialling some new access targets, and these are likely to change the more traditional ones that we've always been looking at, like RTT. And there will be some changes to the constitution metrics, which will then have to go through the correct process. The final report isn't due from NHS England around this till the end of March, so it's sort of watch this space really. So moving on to the public health section. So this is appendix 2, sorry. Okay. So appendix 2 sets out the range of outcomes set in the performance framework for public health. It shows that across the comparable indicators, 19 are RAG rated as green, 12 are amber and 3 are red. Of the 19 green, there are some areas though that have reduced their performance. However, they're RAG rated green because they're still better than the England position. And these relate to the prevalence of overweight and obese children in reception and year 6. And that's shown a significant worsening in performance. There's also been a decline in performance around breast cancer screening coverage and cervical screening coverage, and certainly around the overweight and obese children, that decline in performance has been witnessed nationally as well, so that's a national trend. Of the 3 red indicators, they are chlamydia detection rates, which show that Leicestershire have declined below the benchmark, and they're currently ranked 19th out of 16 of the neighbours. However, there has been a slight improvement over the last 7 years. Second one that's also rated as red is NHS health checks, and the third one relates to physically active adults, where Leicestershire is ranked 15 out of 16. So that is the report. Obviously happy to take any questions from anybody.
So, questions, but also I don't know if you may want to make some comments. I'll leave that.
Thank you, Chair. Not so much kind of comments about what's in there, but comment about what's not in here. And LPT's never events. I must admit, a slight kind of reticence to believe that LPT has no never events, considering the recent issues around safeguarding, certainly around the Agnes unit. And in their last annual report, they cited over a year period that they had 0 never events. And whilst this may be just down to a very kind of splitting hair of what means a never event, there just seems to be kind of something missing around that. And I just wondered if it's something that, is it there or?
Fine. So the never events, there's almost, not quite a list, but yeah, essentially a list of things that would constitute a never event. So it could well be that LPT hasn't had anything on that list. However, they should also be reporting around serious incidents as well. And there isn't, don't believe there's actually anything to say they have to report in terms of formally reporting through board around serious incidents. I know UHL do, because that's where we get a lot of the information from, and certainly through the national reporting system, there isn't anything to say they have to tell NHS England about never events or serious incidents. But it's definitely worth progressing somewhere. Okay.
was going to be about never events as well. 'Cause it talks about the 5 at UHL, and I know we get the regular updates. I suppose, although they're small numbers, I'd be interested to know, we could do it outside this meeting, what the trend has been over time, because it feels like it runs about 2, 3, 5 feels a little bit more than they normally report. So I've lost. Oh, is it? Okay. Yeah, because it's one of those ones. Is there a base level? What they're doing around that? But I thought it was worthwhile just reflecting on the rolling trend over the last few years. There's the obvious question about trying to work out what the foreign body was that was left in. If it wasn't an accountable item, and therefore it wasn't a piece of surgery equipment that was on the tray, it's like, what was that?
I think it was his Fitbit watch thing.
Yes. Yeah.
So there is a lot of information on that Never event within the public board report. I didn't include it in here because I didn't really want to, but but if you go to there, I think it probably been there October or November public board report. There's a whole section around it. So.
Fine, I think we're probably up.
Just to comment on the public health one. I know most of those we've covered in the past, so chlamydia, I've always said, will always be red because the national target's a combo of coverage times by the number of positive cases of chlamydia you pick up, and we're a low prevalence area, so, you know, it's one of those ones that I'm hampered by one half of the equation and would have to screen 100% of the 18 to 24s to get anywhere near the target, which wouldn't be a great use of money. Physical activity, members will know, I mean, that's, you know, my annual report, I'm sure, will make a huge difference to the figures and will turn things around in the course of the next 8 months, so I'm looking forward to that happening. The question for me, though, is around the childhood obesity figures, because isn't that last year's figures where we were significantly worse than national average, but it was the measurement problem in Hinckley and Bosworth? So if it's this year's figures, I'd be surprised, because we've sort of reverted to the mean, so I'm not quite certain that the new NCMP is fed through into the national profile yet. When it does, I could confidently predict we'll make the best progress of anywhere in the country, not because of anything we've done, but because we've got rid of last year's data problem.
We always breathe in when you say Bosworth.
I mean, certainly in terms of CCG level reporting on those metrics, we were reporting on 17-18. But whether Cajul's got something more up to date, I suspect you're right. I think
There's the 18-19 figures are now out, and that should bring it back into line.
Well, we're doing my bit in my village. Our parish council's put 4 items of adult exercise equipment in. I'm just waiting for it to stop raining so I can sit on the seated one so I can actually do the various exercises. But yeah, and we wrote to all the people around the little park where we've put them, and there's been a huge amount of interest. I think they're like me, all waiting for the rain to stop.
It's a shame, really, we've had to wait to the end of the meeting. I know there were so much other important items on the agenda, but looking at page 102, all those reds, I mean, you can't just say, just note the report. Some of us living in this room are living with cancer, and you know, this is as serious as it gets, isn't it? And I'm just wondering whether we ought to have a further report on this to ask what's to be done, what's being done to try to improve the situation.
I mean, this is only October. I mean, we're already 3 months. We can't, but they can. I mean, the only comment I have made is that this is all full of percentages. That obviously, and it'd be nice to know some of the numbers. Yeah.
I mean, I'd echo your point. I think it would be quite useful for you know, the cancer lead across Leicestershire to come and talk about what's happening in cancer, because you know we can you know, I'm not employed by CCG or UHL or LPT, so I can tell you what they're telling me, but there's nothing better than hearing it firsthand, really, is there?
Okay, everybody now done. Thank you very much. So we come to the end of the meeting. Next meeting of this committee is scheduled to take place on the 4th of March at 2 o'clock. Those of you that are on the joint health, we're meeting next week, 18th, next Friday, and then again in March.